situations. We are great among us, Dr. Basab Mukherjee, speaker, to take this session ahead. Dr. Basab Mukherjee doesn't need an introduction. I'd like to say just few words. He is Vice President-elect of FOXI 2022 and Organizing Secretary for 2022. He did his mentoring from CMC Vellore as FIGO Coordinator South Asia Abortion Committee. He's a routine for RCOG examinations in India, teacher and great researcher. He is of ICOG from 2015. Has served as Honorary Secretary for Bank Society and has also received, including one Young Gynecologist Award FOG in 2011. He has also served as past chair for FOXI between 2013 to. He has many publications, international and national journals, speaker at international and national platforms. This would request Dr. Basab Mukherjee. Over to you, sir.
Thank you for the kind introduction. I would like to thank Dr. Al for doing a wonderful, difficult year, and a pleasure to be a part of this E-Sampark webinar. Programs which are happening through this year, this was something which to be a webinar from the beginning. Modules which were already planned by Dr. Alpesh and Dr. part of their work throughout the year. Our academic partner Lupin this program forward. So this is which we are having, and this is contraception needs in special situations. Half an hour, I would like to take your subject, and if there are questions in the next 15 to 20 minutes. Contraception, special needs situations. Family planning could bring to more people than any other single technology available to the human race. Something which we know, something which we believe in, we appreciate it in our clinical practice. So family planning alone, more benefit to more people, less cost than any single technology now available to the human race. Thing which comes closer to this possibly. So the which I would like to be highlighting 30 minutes would be some age groups. We will be looking at reproductive age groups which are special. The adolescent for contraception, the woman after the age of 40 for contraception. We'll talk about to reproductive events, special situation just immediately after, or a post-abortion situation. We will have an opportunity to discuss known gynecological issues. Women in our clinic walking up with different gynecological issues, polycystic ovary, abnormal uterus, and then what contraception would be. There are known medical that women may have at different age groups, especially hypertension, diabetes, obesity. This may affect the contraception that we can offer, eligibility of the basket, and what is appropriate to her. That may be having some discussion on that issue. The COVID pandemic, which is a special, and in the COVID pandemic, several challenges in the both in the public sector, which is a good idea to. We'll talk about self-use of contraception, long-acting reversible contraception, health, how it becomes important in awareness, in compliance, in follow-up, and in initiation of contraception. And also we'll be highlighting in the special needs who have disabilities, who are and contraindication, the religious the use of contraception. We will look in briefly. So the extremes of reproductive age group, a comical strip where is shouting at his daughter, pregnant, how could this happen? His daughter gulps down her, guys don't know, then I must. So obviously she's saying that went on to have sex, but their parents must be knowing about it, have come into the world. So the very young, a few young people receive preparation for their sexual life. It is difficult to sometimes have in the clinic, but it is a truth. Even when we go out to discuss colleges about of women's health care, I think safe abortion, safe sex, important aspects which are integrated in discussion, and we do talk about them. Few and very few drops in the ocean. Young people are very inadequately their sexual debut, and it also really vulnerable to coercion and exploitation, and also the pregnancy and sexually transmitted, including HIV, which almost the woman in many cases has. So this is the state UNAIDS, UNAIDS, UNICEF, and WHO, which just the truth. So adolescent, very important issue, and it's a very situation because it's not something which you come to keep in mind. Premarital is increasing. There is no doubt. It's very common, especially more than the rural. But all there is a very change fabric, and that's not something for debate today. But we need to that premarital sexual activity, and so is the unmet need for contraception. The women at that age generally are informed. There are a lot of knowledge. They would not necessarily know their best interest to use, and some hearsay over the counter, some neighboring advice. Likely to prevent pregnancy, more likely abortions, and have them late, them to a lot of risk of their health and complications. They're also more likely to have more than this time. Often the flings are temporary, and that you may have more partner, which increases sexually transmitted diseases, especially not used, and also HIV. So in adolescent counseling issues which need to be addressed, and talk about adolescent friendly health. Talk on that when you talk about a seminar. Idea generally would be relatively the same. Ensure confidentiality before you discuss about contraception. Avoid time restraints. Don't keep on looking. Say just avoid the skirt the issue. Avoid the fast, and your next patient is on the line. Need for other services besides contraception, because it may be something else. Assault, different, maybe STIs, maybe counseling. It may be something beyond, but at least you can direct her to some which she may at that. Also, it's important to practice within the existing laws. So the POCSO Act very frequently discussed now in a lot of webinars, appropriate reasons, because all of our guys are fully aware about the implication of the act when a woman under the age of 18, either a sexual problem, asking, becoming pregnant, asking TP, what are the frameworks have to act, informing authorities. All that is important, and by every practicing. Same for the MTP Act. What is the filling the forms, the consent forms? The age is appropriate, the age is not appropriate, and how to place her, and how to offer her. Those are so generally, I think in adolescence, it's fairly evident that dual contraception. We should advise and a hormonal contraception most effective. The barrier would like preventing the STIs or minimizing them. Contraception would possibly be the best group. But again, what you decide may not be best for them at the end of the day. And there are knowledge emergency contraceptive pills, planning methods like coitus interrupt. Times when you have these helplines, we are in practice, so they keep on asking about. I had they fell outside. Will I become pregnant? And etc. That there in natural family planning method practice without knowing that they're not. Emergency contraceptive pills discussion being available over the counter, use and misuse are something day-to-day practice, and a lot of gaps. Coming to the other end, so adolescent contraception was one. Late pregnancies after. I know this is a super hit movie, couple shot into the picture. Ayushmann Khurrana gave some really worthy answers out there besides all of them here seen in the screen. That was just trying to highlight the age of women getting pregnant and the cultural issues. Though that wasn't a, but I think we do understand that we're 40 unwillingly and pregnant, and there are issues of contraception at that age. About the side effects of contraception, sometimes even more than even 15 years earlier. There's of reduced fertility. So some people, as you will not be, but there you have to be. The fecundity of some women is very high, pregnant, even with sort of intercourse, and so there differs from woman to woman. Medical diseases which a woman picks up by the time she reaches the age of 40, and those may affect the contraception which she giving her or offering to her. So that in special categories where the medical, which we will be discussing soon, is then the eligibility picture, and that is a different discussion. Issues of 40 plus one, when to think that she is no fertile, and then if she has an IUD after the age of 40, we know that you 10 years instead of 5 years, and that give her protection till the age of. Even if she has combined oral contraception, whether she can use it for a long period. Often during our we have is both among GPs just till how with what OC pills. So some people say 35, 40, 45, but that you can give it till the age of as long as you keep on periodically evaluating, finding out that she has benefits are outweighing the risks. So COC oral contraceptive pills need to be regulated. Any woman given for a prolonged duration, but it is not contraindicated in case of diseases. She doesn't have others not there, then there is definitely something where a long duration of time. She carries more risk in these women. It's not just about the socio-cultural issues, medical problems, the issues of increased labor, postpartum hemorrhage, delivery, all increase. Use of the special areas of contraception regarding reproductive events, Partum and post-abortion. This is a graphic diagram of contraceptive use at different delivery. So this is recently from the WHO to postpartum family planning compendium, and here we progestogen only, which can be used almost immediately. So the implants are used immediately after delivery. And only pills can be given immediately, which were not there before. Reserved for after 6 weeks. Feeding, of course, you can give the injection of a delivery. That is also, know that condoms, spermicide, it can be used anytime, immediately. For female sterilization, and for there is a break in between, postpartum or after 6 weeks, already know. So this is very useful for a postpartum planning, the methods which we can offer, and that is something which is to not waste the chance. At this point of time, a woman is there with you in the hospital. She knows that she does not want to immediately because she has had a child. Sure that yes, she is that yes, she is more committed continuing the method which you will be or she will be using before she. So postpartum contraception gives both maternal and infant, estimate the importance of postpartum, and then invariably they come pregnant 4 months, again unintended, and then going for different procedures. So saving life, they may have an ectopic which could be not make out because she's breastfeeding, and you miss out, and suddenly she comes, and then it is most of it is already difficult to win. Same for the very closely seen that the closer you have after a delivery, the lesser chance of an infant suffering born. Factors influencing postpartum case could be breastfeeding, limiting choices, cost sometimes, and availability. Points of time, it is important to understand coercion, never to force a woman to postpartum contraception, as it affects complex stories, multiple stories, different parts of the country where the UCDs are inserted with little before the insertions and a lot of rejection and removal soon. So that's not something which should be about it ideally in the antepartum period, during the intrapartum period, but not responsive when she's having pain. Most appropriate. The most effective of postpartum contraception, reversible contraception, IUCD, and implants, is definitely. Yes, there's some people who would like to, some people say no, but that is another we can offer them. These are options. Feeding time, the unscheduled bleed, progestogen only contraception, catered off with the unscheduled breastfeeding. The things which cannot postpartum contraception, even though you took the most effective contraception like pills or progestogen injection, sometimes they do not, and then you say, and they go back to the barrier, to the lactation amenorrhea method. And I think it's a discussion that in case they do not go to modern methods of contraception, lactation amenorrhea method or barrier, they have to get the information that use it properly. They have some protection, and they have to be guided, like always that you tell them to use something, and but at the same time, if they different, they should be guided that they according to that. Methods with irregular periods, highly unreliable, and usually during this phase. Postpartum to the post-abortion scenario. Woman we treat for post-abortion is there because she contraception. We have failed her. She leaves without family planning, failed her twice. So these were May 26 years ago and till today. So if we anybody is undergoing an or medical, there is an intervention there where you need to talk to planning, because no woman would like abortions or repetitive things. To always have the contraception method which you advise them, but nobody repetitive abortions. No woman does an abortion. I think that is something which we should all, and it has to be, it's imperative abortion, we discussed with her of family planning that she either not used or she has misused, she's pregnant unintended or unwilling, what she can be taking, what she should later. So I think the husband and should come in the decision making, able to make it alone, but at the same time discussion which cannot be avoided. So contraception, the importance again, as it's accessible, the woman is there. If it is a surgical method, if it's also the woman is there in the clinic, at least you and you have an option to. She is motivated. She's assured of compliance. At least for the next few minutes, will be listening to what you are. Poor awareness about regarding people who do not use it. Save it up for. Decide that they will take the decision. Do not always know that how fertility returns back after she can get pregnant even after 12 if she has an episode of intercourse. Influencing choices would be spacing or cost, efficacy, availability, and again, say never use coercion. Sometimes you see women coming again and again with abortion when she's not using contraception. You're asking her, you're pleading with her, but all said and done, ultimately the choice. You cannot force her to do a contraception. It always affects compliance. Never in any fabric can we force her and coerce. So the most effective would be reversible contraception. Again, you can. She doesn't need to pop in daily pills. Effective and will help her to go. Cannot be ignored for post-abortion contraception. For the postpartum too is barrier pills, because these are something which keep on using, and these are the ones we ignore. Abortion contraception. So what are the barriers? These are the negative provider attitudes, especially in the sector. We know that some of the Partum IUD has been there in the sector, which hasn't been exactly reflected. And that is the reason why very few care providers are confident of there is a negative provider attitude. We all know that our clients or other women will not accept it. Some of them take the effort always to discuss it with, because we often assume that it's not a very popular subject and altogether. So there's little or no counseling, eligibility or availability of rapid return to fertility, lack of services. A woman cannot. So once she comes for vaccination of a child, some discussion which has to happen about contraception is not already using it. So that those are integral in the healthcare system. Maximum benefits. Myths and conceptions methods has been there from ages, persist for many more generations. There has to be a continuous effort to accept them and try to work on known gynecological issues, polycystic, etc. There are non-contraceptive benefits, which is often the reason why we use them in the first place. It is often the primary reason for contraceptions, and that is what we sometimes see. So the woman is given not because she's just sexual, but because she has a coexisting problem. So often, the most often is where she is offered ethanol, either drospirenone or cyproterone. In a middle-aged Paris woman, she may be offered a LH, which takes care of both the things. She has bleeding there, and she also has a birth control. Ovarian cyst often settles. But if you want to give some medicine, cyclical combined oral for 3 months to see the difference. With endometriosis, you can't say just all the time. This woman, yes, so you need to give her something else. Continuous OCP is there. It takes control. It takes care of your endometriosis temporarily, and that is something which offered to her. 40 active with adenomyosis, and an LNG-IUS is something that can be offered to her, which could possibly be treatment for adenomyosis and of her birth control. So here we are, contraception, special situations, FOGC. So the next section is on. So this is one important aspect, I think, why we have this topic about situations where special needs to be considered. The issues to address here is if a woman has a problem or a medical disorder, fears and myths of the with it. So generally the topic is not a very popular one. It's not something to bring up when you discuss in a clinic. A medical problem, it always gets excuse to skirt the issue. And for the the risk of pregnancy is increased in these women because pregnancy risks more than a pregnancy who doesn't have medical disorders, and also side effects of the contraception on the condition. So if you use hormonal contraception, diabetes, can it worsen? In blood increase, in asthma, can it worsen? Can it worsen? We keep on guessing, extrapolating, which is very normal and natural. And that if a woman with uncontrolled diabetes, that's a problem. If she with uncontrolled pregnant, that is the problem. So this is also pregnancy with added risks to. She needs to stay protected. She needs to, but again, there's worried about which one to. So here comes a very important care. The main areas are the personal history. DVT may be a problem. Past may be a problem in some cases. About smoking, lifestyle things, family history, past history, family history of DVT may be a thing. Past medical problems, if she has any, influence your choice before you, because that one may not be the appropriate one in her possible case. So there is a doubt. I think an important document table is the WHO medical, the latest of 2015. WHO medical eligibility criteria for contraception. Have the wheel, you can have the, is something which is the most user friendly. Write to WHO, they can post it at the clinic. Otherwise, it's available at most NGOs who work on the grassroots. And at that, the Indian, under the guidance that from AIM, India Family Welfare had also brought up a wheel for the Indian, and that was of the purple color compared for the WHO. So the WHO or medical eligibility criteria for category 1 would be no restriction. Category 2, where advantages out or proven risks. Number 3 usually outweigh advantage. 4 is unacceptable. So for where do you want to use them? So if you want limited clinical judgment, though we are not really limited clinical judgment, but for a moment that all of us have limited, then let's stick to 1 and 2 and let's 4. But if you want to really, with all of us do possess, then we could do 3, and also in some cases always avoid 4. So just a couple of examples in this presentation. So contraception. So if a woman has high blood pressure, contraception. Well, yes, she needs, but which one? Depending on how much of blood control blood pressure control. So if the blood pressure control, that is it's possibly, then you can progesterone only pills, that would be there. Category 1 there. Then there is, which is again in category 1, IU category 1, implants are category 1. Would be most of your hormonal combined oral contraceptive pills, contraceptive, would all be category. Similarly, if it's diastolic more than 100, then it's category 4. So basically, the once you have pressure which is not controlled using a combined hormonal contraception, would be less, but you can use contraception in these cases. Contraception in diabetes. What about diabetes? You see in the insulin dependent is under control. It's all too use almost anything. Same for you can use almost anything. So if the woman has diabetes, you cannot. That is absolutely ill-founded. That should not be there at all. If you have associated vascular, there will be some restrictions there. Coming to a little special situation about how do we see contraception times and how is it different? Most of I think the attendees that from this data of which is a very important NGO work control over the last many, they have come out with this the access point by the population because the pandemic has which have been unable to access contraception 6 crores, and this will be 3.7 lakh unintended in these 6 months, 13.4 unsafe abortions, which is quite bad, 0.79 live births, and 743 extra, just because contraception has been able to be provided in these days. And so contraception in the COVID times has to be on the integration of healthcare. So the postpartum, post-abortion, I did mention before, just have to the maximum now. We have to with the woman, try to convince her visiting clinics or hospitals be limited in these days and times, limited because of fear of infection and limited because of the facility. So definitely which you may be facing of long-acting reversible contraception of repeat visits would be minimal, be very efficacious, guiding with self-care methods if they're on emergency, how to use them, when to use them, most effective. They're not 100% replacement for conventional contraceptive to keep plugging in the knowledge gaps. Fertility awareness methods, fertility awareness methods, which are the time roughly, which is the time to avoid subcutaneous DMPA, which again is how can that be done every 3 to 4 months, where a couple may need guidance done either through technology can be adopted in providing the gaps, addressing concerns, patient visits. So we have the social media where a lot of being generated and being passed on the women and the couples which they cannot because of avoiding face-to-face healthcare provider. There are also issues of distribution in the medical supplies, which you'll be hearing a lot is coronial, which is not born yet but will be born of enforced quarantining of their parents in the COVID-19 pandemic. So all your years ahead for you. So if you are alive and all right till November this year, I think the labor room and a lot of deliveries are up on the card. Meals will be delivering from November, I think November 2020 onwards. To a little bit in the last part of this talk, with special needs, disabilities. So contraception for the differently abled. So there are women who have mentally, physically, and for them would be ideally suited in a fair amount. So LNG IUS or IUD would be good. Methods reducing may have added benefits for women who are unable themselves, unable to dispose them efficiently. Consent and confidentiality have to be addressed. Guardians who have to be brought into the picture. For signs of sexual abuse or STI, women maybe regular follow-up for side effects and important. Religion opposes I think there is an argument for in our contraception discussions out the religious heads to try to bring a view which often are contrary to what people think. Often the devil lies. So it's not that any contraception, any opposed to contraception, but it is at the same time the interpretation of the holy is sometimes differs. All said and done, you need to respect the decision. They are opposed. You do not change them to always get back. So they only opt for natural methods where coitus interruptus and standard day method are with limitations. So of which method is something which I think I just want to, it's a self-reported cycles of 2 days. So once you count the days of the cycle, they are regular, roughly between 26. It is an option which women can have. Cycle beads, there are different colors, a small movable ring, one bead to another bead as one day. And then on the beads are the ones in which you can not, white is when you can have intercourse and on moving them. So this was developed by George. It is fairly simple once you're it, and then there is the trials which are done. It's a 4%, 13 cycles of correct use, which is bad. To the takeaways of this talk, special needs in special situations existed and will always be. As healthcare providers, it is our discuss contraception at every opportunity, realizing its immense potential and job in trying to give the best to visitors. The choice of choosing a contraceptive solely the couple, and we cannot force, even though it may be in their best interest, to choose depending on the options which we give. In most cases, though there are indications in specific things, benefits outweigh the risks. So in most cases, 55% of cases, you will be all right. Maybe in 5%, you need to be careful. Sometimes you may need to avoid one particular. Myths and misconceptions have will always be there, and integrate all the committees of the family will see on the public awareness committee. I think we can say is that questions need to be addressed, and these are which have to be continuous in the doctors, healthcare providers towards the public. I'm done with this talk, and I'll be happy to take questions which you may be having.
Thank you very much, sir. Yeah, thank you very much. An insightful session on a very important. So we have received certain questions from our audience, live audience. Question is from Dr. Hansa from Mumbai. She's asking that contraception in case of medical pregnancy.
So in medical termination of pregnancy, if you do, it has been said that you can start giving misoprostol. Even if you want to, you can start, let's say, the day after giving. Will it affect the way the abortion? The answer is no. Will it cause abortion? No. So the bleed as it goes on the side, and you can your medicine which will start working as it is. Will it affect the amount? So that is something which is very clear. If oral contraceptive pill, if that is your choice, the day of a medical abortion, the day after medical abortion, or on the prostol. About surgical abortion, keep an IUCD when you're doing a surgery. That is one option. Otherwise, you pills again the day after. That is.
Thank you, sir. Women having only one function, what should be the best method of contraception?
So then you have to look at where is the contraception being. So all the hormonal contraceptions are because that is what you usually check for, or a lipid profile if a woman is on a very long period of time. So nothing So just having one kidney, any of her choices in contraception, open to all the possible choices. Not one kidney does not non-functioning kidney. If she has kidney failure, that's a different thing, because that will be keeping. But other one functional kidney does not there in the medical eligibility criteria. Should be looked anywhere different.
Sir. So Dr. Jayesh from can you please briefly explain the choice of contraception for old women having hyper and diabetes?
Yeah. So hyperuricemia has no effect. Contraception has any contraindication in hyperuricemia. It also be said, unless it's a prolonged diabetes years causing vasculopathy, hormonal contraception can be used. Factors will depend on other issues. To obese, if she has a BMI of more than 5, if she is a risk of disease, metabolic syndrome, in that, like to minimize the use of estrogen hormonal contraception, then you may think to would be one option. Pills would be another option, but the issue of unscheduled bleeding, regular contraception before that. But and diabetes per se does not change her. She can almost go through anything, but you need to look at the woman at whole, periodically evaluate her. So you can contraception and leave her every 6 months, balance benefit versus risk changes, then you either need to shift or need to stop it.
Thank you, sir. So Dr. Shashi, she has given compliment. As usual, it's a pleasure listening to you talking. And she has another question, that what is the best contraception in a woman having epilepsy?
Yeah, again, I didn't bring it up there in the slides, but again, epilepsy also contraindication for hormonal contraception. Contraception can be given, but if you want to always give a IUCD would be if you want to, but there is nothing to say. The other thing about epilepsy is the drug vis-a-vis the hormones. You may have them, but that is not something where it is not something that you need to change the formula. If you want to avoid hormonal contraception, then you may you shift to a, but it's not contraindicated. Epilepsy, you can give her all the.
Thank you, sir. So Dr. Neelim is asking that husband is allergic and wife is a breast cancer survivor. Age, what is the contraceptive of choice?
Question, huh? We keep on mixing and combinations will keep on coming up. So allergic to condoms, we want on her throat, so let's leave that out there. So barrier is gone. Breast, whether can you use hormonal contraception? Everybody will be skeptical to use. Estrogen is out. What about progesterone? Well, breast cancer survivor, PR things you just think about. So avoid progesterone. The best thing is your eye that won't have anything. But usually estrogens can be offered, and that would be another IUS or a progesterone only. Possibly most people would like to where if there's a breast cancer history in the it would be mainly an IUCD. That would be there, no question about it. The next the IUS, possibly that would be another option. Out estrogen containing contraception, preferably avoided.
Thank you, sir. So I think a repeat question you have already discussed in the are on hypertension again.
Hypertension, I just want to reiterate, Vinay, that is one thing. If the medicines do not then you need to avoid contraceptive, and that is where contraceptive pill will be out. But an option with the added problems of unscheduled bleeding, and counsel, because any form of contraception, whether you give pills, whether you give LNG IUS, whether you give impulse, always have some amount of unscheduled has to be counseled before you and periodically evaluate she may even just counseling may not do medication, which may need to be at some point of time.
Thank you very much, sir. So I think we have questions. Thank you so much. We run the session. I think you have covered populations in this brief session. So on behalf of entire Lupin, all the viewers, I would like to thanks to you. We are really grateful to you. We will be very listen more from you on other topics.
Thank you, Dr. Vinay. Thank you. Thank you for attending and later.